Good morning, everyone. Thank you for joining PHCA for today's webinar, CHC Lessons Learned. I'm Wendy Johnson with the Pennsylvania Healthcare Association. Before we begin, I have a few housekeeping items to cover. PHCA offers monthly webinars to members to receive updates from department staff on regulations, learn from industry experts on current trends and practices, and to gain a better understanding of practical application tools to equip you so that you can continue to provide the highest level of quality care possible. This webinar is being recorded and will be made available on the PHCA website. The webinar has been approved for 1.5 continuing education credits for PHCA members. Credits will be uploaded to NAB within the next 2 weeks for those who have provided us with your unique NAB number. I'll be sending a link to a quick survey. Your feedback is important to us and our speakers, so please take a moment to complete the survey. All attendees will be in listen-only mode. However, throughout the presentation, please feel free to submit questions using your questions pane on the right hand of your screen, and our presenter will address them throughout the presentation. Now for today's webinar. Today's webinar is being presented by Cynthia Haines, Principal with Post Schell. The implementation of Community Health Choices program has brought historic change for long-term and post-acute care providers in Pennsylvania. Since January 1st, 2018, your colleagues in the counties affected by Phase 1 and Phase 2 have been operating under CHC. This webinar will allow you to learn from your colleagues that operate nursing facilities in these zones of Community Health Choices. Having assisted 10+ providers through contracting and implementation, the presenter will share the steps providers took to prepare for implementation and some of the challenges and successes they experienced. The presenter will offer insights regarding contracting, claims processing, working with service coordinators, transportation services, participant enrollment and eligibility, working with the IEB, and other issues they faced under the CHC program. I'll now turn the webinar over to Cindy.
Good morning, everyone. As Wendy indicated, this is Cynthia Haines. I'm an attorney in the Harrisburg area, but I've helped folks in both Phase 1 and Phase 2 in working through the contracting processes with the MCOs. So without further ado, I will get started here. One of the things to keep in mind is fee-for-service, as it had been through the medical assistance program, has been slowly waning, as everybody has observed. But the state is, with community health choices, and the MCOs, behavioral management health choices, really looking to get out of the medical assistance business and to be administrators in the program, and to provide the insurance, which is what MA really is, through HMOs. Of course, it's the wave of the future, connecting payment and service delivery with performance on the side of the healthcare provider, with incentives being made for good care. That's ultimately the goal. So with that said, you'll notice a lot of themes throughout the Medicaid contract. The state is really stepping back from liability, responsibility, including grievances and appeals for the process. So that's something to keep in mind, that ultimately the relationship that you have to build is going to be with the MCOs. And unfortunately, it's not a one-stop shop. There are 3 MCOs that are in the business. Pennsylvania's goals have been the same. This has been what they've said since the beginning, and that is to increase opportunities for community-based providers. That is to get away from institutional settings for participants for long-term care services. Now, there will always be a need, of course, for facility-based services. We all know that. And I think the state knows that too. So it's one thing to keep in mind as we move forward. To strengthen the delivery system, a big one is to allow for new innovations. We're not seeing that early on in this process. Again, the whole state has not been brought on board for community health choices. So the state has not yet rolled out what they're going to allow the MCOs to do with regard to new innovations and incentives for the new innovations. One thought is that some of this will track what the federal government, what CMS has done with regard to payment for provision of certain services and innovations, and better enrollment, disenrollment, care processes to gear folks, keep them healthier, and keep them in lower level of care. Promoting health, safety, and well-being. Again, these are initiatives that the state and the MCOs have not yet gotten into. With the rollout, this is what is ultimately one of the goals. And finally, ensuring transparency, accountability, etc. All of those things. I'm not sure. I think the jury is still out on how that's going because everybody has been very busy with just getting the program up and running. You've probably seen this chart before. The Southwest was the first region to be up and running. And of course, that was fraught with initial enrollment issues. There was a lot of late enrollments, et cetera. So the MCOs had their learning curve and faced some difficulties in enrollment. My understanding is things are going fairly smoothly right now in the Southwest. Then the Southeast, and of course, being a very populated area, that was fraught with different issues, and there were a lot of late enrollments for providers even then, and a lot of automatic enrollment of participants because it seemed to be a rush to the finish line. Things have seemed to be a little bit more efficient and thought out for Region 3. The unique issue with Region 3, which I assume we have a lot of folks on the call are Region 3, is that it's very rural. So it's very different than the two other regions, generally speaking. So that has unique issues that the MCOs are facing and the providers themselves. Most of what I'm going to convey to you really is common sense. For any kind of contract negotiation, it's important to develop relationships with the managed care organizations in particular. I would highly recommend, if you have not already, having a first meeting with the MCOs, learning about their processes, asking them to explain how they're different from the other managed care organizations and what they can offer to you. Secondly, find the right person in the organization to talk to. Oftentimes, you may have a sales representative that is knocking down your door. Oftentimes, that individual is not necessarily a decision maker and can't make decisions on the documents themselves and whether or not you can negotiate any of the terms of the documents, but also some of the operational requirements. I think it's very important to be able to talk with the right person. And my third thought about that is to be tenacious. They are very busy and things are often very hectic with them. So it's important that you get on their radar and stay on their radar. And because we're so late in time and the next round is being, everyone should be signed up by the beginning of the new year, they are very busy getting these contracts in place. Finally, the negotiator, the person that's actually going to talk with all the MCOs, should be armed with all the right information moving forward. And that means information from the various areas of your business. I often recommend, especially to larger providers, to have a team that meets on the managed care implementation that's reviewing varied parts of the contract itself. For example, a credentialing team reviewing the credentialing section, so that the person that's doing the negotiation is very well informed. I also recommend having an all about us type of binder that you share with the MCOs that talks about your population, your bed count, some special services that you have, anything that would make you different and potentially make your affect your rates. Is there any reason why you should be outside the regular payment rates? Do you provide specialized services? Are you serving a specialized population? This is the phase 3 timeline right now. This is addressing participants in particular. Participants are now receiving their enrollment packs, and they should be looking over their enrollment packs and talking with you and also the IEB, the independent enrollment broker, about enrollment in the managed care organizations. In Region 1, in the Southwest, a majority of individuals were automatically enrolled because I don't think the process was explained well to participants by the managed care organizations. My understanding from the facilities that I'm helping right now through their contract process is that the managed care organizations have been doing a much better job in informing participants and reaching out to them and doing their own marketing. Plan selection is coming up here quick. You might be hearing from your residents and the folks that you serve about selecting a plan. If not, they will begin to auto-assign folks, and we'll be talking about that a little bit later. January 1, 2020, the contract should be signed and phase 3 implementation will begin. Again, these are some of the things to think about, and these are things you should think about for all contracts. Do not procrastinate. If you're going through these slides and thinking about what to do next, I recommend that today you pick up the phone and call over to the managed care organizations and ask them to send you the paperwork, and also ask them for a meeting in the next week or so. Again, make sure you're talking with folks who have authority, especially if you're considering pitching some topics, some things that are special to your organization. For example, if you take care of a lot of people who are on a ventilator, or if you take care of a certain special population. Again, set up those meetings now. This slide really goes to what should be in the binder that I'm recommending that you set up. I call it the All About Me binder, being all about your facility. Know your market, know your region, know what's offered in the region. Understand the provider network, and even more than that, have a list of the ancillary providers that you use now, and reach out to those ancillary providers to be sure that they're in network with the managed care organizations to prevent problems for your participants and residents down the road. Be able to demonstrate your value and your differences. What makes you different? Do you provide different types of services to your residents that are necessary and above and beyond what others offer? And finally, for any negotiation, what are your most important issues? I always recommend taking in with you when you're talking with anyone that you're contracting with, what are your deal breakers? What are the things that you really cannot live without? And also have a laundry list of things that you can use and are willing to use to compromise, because that's always necessary too. As everyone should know by this point, I think the department selected 3 managed care organizations across the state. They are AmeriHealth Caritas, also known as Keystone First, UPMC, which of course had a very strong market share in the Southwest, but is moving and getting stronger across the entire state, and PA Health and Wellness. The interesting thing about PA Health and Wellness is they're a subsidiary of Centene Corporation, and Centene has implemented this program or programs that are similar across the United States. One problem is that they came in and they didn't have strong market holds, so they've had a little bit more of a problem getting up and running. But what we've noticed is that once you are enrolled with them and things are working out okay, things do run smoother because they are used to this particular type of what they would call as an insurance company a product. The facility does need to contract with the 3 plans if they want to accept residents who are enrolled in Community Health Choices. And contracting with them is very similar to contracting with other MCOs. And in fact, much of the paper is addendums to other agreements. I'll go through what the paperwork looks like because it is daunting. Most of the terms are fairly similar, but the paperwork does look different for each of the 3 MCOs. So when you receive the paperwork, Pennsylvania Health and Wellness, they have an overarching participating provider agreement. Generally speaking, they only provide Community Health Choices managed care and Medicaid programming. So their paper is generally a little bit simpler. They do attach the Medicaid requirements, and then the Schedule B is their Community Health Choices. But again, that is the major product, so they don't have a lot of other attachments on that. If you already have a relationship with, for example, Keystone or UPMC, your paperwork is easier because they only send an addendum, but it's a little bit confusing to go back to your master agreement that might already be in place. So for AmeriHealth, you would have a master agreement that may or may not already be in place, an ancillary provider agreement, and then attached to that would be a Community Health Choices addendum, which is a shorter document, a shorter attachment. And finally, for UPMC, they're set up similar, except you will receive 3 documents. There's an ancillary provider agreement, master agreement, the amendment to the provider agreement, which the amendment is not actually an amendment. It's more like a Community Health Choices attachment, but that's just their vernacular. That's their name for it. And then the nursing facility rate sheet, which that by far is sort of my favorite setup because the rate sheet is set up and you can negotiate for some things, added provision like a relook after 13 months at the rates, and UPMC will promise that, but it's set up fairly clearly. I'd like to talk a little bit about some of the concerns to think about and some of the things that we've had discussions with the managed care organizations about as we move forward. And think about what's important to you for your operations and your facility. As with any contract, it's very important to look at the definitions because definitions affect the whole deal. Some of them that we've looked at and talked through with the varied MCOs are the clean claims language and medically necessary language. It doesn't completely match the definitions that are in the agreement between the state and the managed care organizations, but they're close. But we've gone back and forth and asked them to clarify and have discussions about what the processes around both of those look like. It's important to understand that for your current operations and current payment operations. One thing that we have learned, though, is that once you're set up with decent billing with the managed care organizations, they're actually faster. This is good news than the fee-for-service payment had been. So, but it's the getting on board that is important, to do that early and to test your claim submissions, et cetera, to be sure to avoid problems as you go through the process. Timeframes, that is one area where several of the MCOs were willing to compromise and provide additional days when the timeframes were not workable for a facility, or to reach a compromise where by a certain time the facility would be able to reach the goal that was in the ultimate contract. So look through and see if there are any operational concerns that you may have related to timeframes. Dispute resolutions and grievances, it's not clear in the contracts all the time what that is exactly, and you have to go to the handbook. I always ask that the MCOs walk through for clients what that is, so that they understand who they need to go to if there's a concern, either a dispute with regard to the facility itself, or what is the participants' process as well. So the contracts are not the be-all and end-all, and it takes a lot of discussion on some of these processes things, including, as you see below, abuse and neglect reporting, the audit process, and PSAE event reporting. This is a piece of information that I just would like all facilities to know. The termination procedures in the agreements themselves do not set forth the procedures that are actually in the MCO's contract with the department. The MCO, if they're going to terminate you, they have to go through these different steps. They don't like to put this language in their actual agreement, but I think it's an important provision for all facilities to see and understand before they contract. The MCO has to notify the department, has to submit a termination work plan, notify residents, and pay for up to 60 days until another provider begins to provide services. So this is one of those things that a little bit of knowledge could go a long way. Hopefully you're never in that situation, but put in the back of your mind that the termination procedures aren't exactly what the CHC-MCO is required to do with regard to the department in the event of termination. When you are stepping back and doing your contracts or working on your contracts, some of the things you have to be aware of is other parties that are involved. We talked about having your other providers, such as eye doctors, pharmacies, making sure everyone's in the network so that things go smoothly. But another issue is, who are your affiliates? Are you part of a chain such that you should have one agreement with just separate fee schedules, or are you unaffiliated in that you would want to have separate agreements for each of the facilities itself? Who are your important subcontractors, and can they comply with all the requirements? Are you part of an IDS, a delivery system that involves hospitals, health systems? It may be important to assure that all of those providers are additionally in the network, or that there's some terminology in the agreement that addresses that unique relationship. Finally, again, the health plan requirements, all the things that the CHC-MCO is required to do are not specifically enumerated in those agreements with you. They always want to hearken back to that agreement. So consider looking at that, the overarching agreement with the state as well, for both compensation and programmatic issues. As you're going through the document and you have your team with you and you're all talking about some of the requirements, definitely your compliance folks have to be involved, and they have to understand how some of the regular provisions that affect you, even just as Medicaid providers under the fee-for-service program, will now translate over to the managed care organization requirements. What's the responsibility with regard to exclusions? What are your reporting requirements? What are the privacy and confidentiality requirements? I mean, generally speaking, the MCOs are covered entities, they're health plans, just as the facilities are covered entities and are healthcare providers. So there's no need for a business associate agreement, but there are concerns around privacy and confidentiality. Their business associates, their third-party folks, and your business associates. Stark and anti-kickback, and those, of course, you're familiar with, but there will always be a term in the agreement related to Stark and anti-kickback provisions. And your protective services, older adult protective services, and for those serving people under 59, adult protective services. Review those provisions carefully. Don't agree to terms that are actually more strident than what you're required to under the law. There are some things that we found with regard to exclusions, but in the first round, but that the MCOs have actually changed to make more in line with the law itself. Their agreements have had some iterative changes since the first round of compromise. As we have moved forward through the process, the one thing, the managed care organizations have become better at being more uniform with how their agreements look and addressing laws and regulations in a fairly similar way, although not identical. The problem with that is then they're less willing to change some of their language, and there's been certainly less negotiation and compromise in this last round of agreements. However, they have added some more favorable, provider favorable language because they've learned more about the processes and what providers can and cannot do. Always a good rule of thumb is never agree to something that is not within your control. Don't indemnify for third parties unless they have a relationship for you, contractor or subcontractor. Now, when you're looking at the paper, you're looking at the documents itself, keep in mind that the four corners of that contract isn't the end of the deal. Any language that says incorporated by reference, you'll be required to comply with blank, such as a handbook, etc., any policies and procedures. Those references outside of the contract, if they have that sort of language incorporated by reference or requiring you to comply with, that makes it part of the agreement. You're then required to follow that. I know this isn't a new concept for those on the phone, but it happens quite often that someone will not read, for example, the handbook language and be very surprised at some of the strident language in there. We've had some success in the first round, actually, with talking through some of the handbook provisions with the MCOs that didn't really match what occurs for Medicaid, and that was very helpful for all parties. So make sure and take a look at some of the handbook provisions, especially with regard to how it jives with your own operations. I think I got ahead of myself again. Familiarize yourself with the provider handbook. It's important to understand how that document is amended. When do the amendments come out? Are they only posted online? Are you provided notice of those amendments so that you can adequately follow? That is one thing you can insist on, and insist on understanding how each of them amend and how you will receive notification of amendments. Will it be annually, or will it be whenever a substantial change is made, which is, of course, the preferred language. They're not generally subject to negotiations, but you are able to raise concerns and talk about it. And I would always recommend, if you have a concern that affects many different providers, to work with PHCA in talking with the MCOs. PHCA is way ahead of the game in terms of relationships with the MCOs and their knowledge of how the process works. We've been working together since the beginning on some of this. Your team, when you have your team together to talk about this, one thing that's very important to do is to go and talk with the MCOs with regard to admissions and discharge. Those times of change are very important, and the sooner you have those systems lined up to make those processes run smoothly, the better off that you are. Compare what you do now to what is actually in the contract, and how will these two processes jive, and will it be very different from, for example, Medicare Advantage programs that you're already involved in? And generally speaking, yes, it is a little bit different. Identify the roles of the various parties, the independent enrollment brokers, of course, the AAA, the assessors, the MCOs themselves, and the service coordinators, which we'll talk a little bit in a later slide, all important parties. And don't wait until actual admission and discharge to think about these processes. And finally, credentialing. They rely generally on other federal and state Medicare and Medicaid requirements, but there are some special credentialing stuff, and the credentialing documents are actually more difficult and take longer to fill out and go through for the facilities than the contract itself. But nothing can get started. You can't get on their portal, anything like that, until that credentialing packet is filled out. Generally, if you reach out to them, and likely if you're on the phone now, it's toward the end of October, you've already received the paperwork and the credentialing documents. This is probably for another avenue, another person on your team. What are the documenting and the tracking and reporting requirements for the MCOs? How is this different from fee-for-services? Who will be doing it? What will the forms look like? And don't expect uniformity across the varied MCOs for these processes. Someone needs to sit down and think about this and track. In each of the varied documents, there is references to audits and reporting, and also in the handbooks themselves, and that will get you started on understanding the process. Again, that may be a different contract at the MCO, but that is something to work out before the deadline is actually in place. Now, this is definitely not my area of expertise, so I'm only going to touch on billing slightly. I do know that all of the MCOs allowed for testing. I don't know if it's too late to go through that process now. If it's not, I would ask the MCOs if you could do some testing of claims submission. Before you actually have to bill, be careful to understand the processes, understand the coding. From what I've heard from other providers is that in the Southwest, there were delays in billing and reimbursement initially. But again, that process has been worked out, and now it runs very smoothly, and it's actually faster than initial fee-for-services. So once your credentialing and systems are all in place and you've tested your billing, you likely can look forward to smooth billing processes. But like any type of enrollment, any kind of glitch could occur. What we do for any kind of setting up in the payment systems, in the computer systems, anything from a small typo to a code problem can have a glitch. So testing is very important, and to having it run smoothly. This is another one where timing is of issue. Clarify that you're able to meet the time frames that are in the contract. And if they seem unworkable to you as an organization, talk with the managed care organizations sooner rather than later. Assess resident impact with regard to any of the payments and procedures. Generally speaking, the resident should be blind to any changes once they're enrolled, except for potential service changes. So assess to be sure that that is actually the case, that there is no impact on the resident. On PHCA's website, there is a contract provision checklist that goes into much greater detail, and you're able to check off what some of the requirements are. I worked on this with PHCA, and it's a good tool to walk through, especially if you're not used to the contracting process, and it's a good tool to sort of split up the tasks among those who are on your work team, if that's the way that you're doing that work. Here are some of the things that you would be looking at in the language. And on that checklist, we have some descriptive information about each of these terms that are in the agreements. Again, some of these are really not prone to negotiation, but the checklist will help you to determine who would be responsible for follow-up and for assuring those things. I mean, in the contract itself, there are promises that you as a provider make. So who is in charge of assuring that those things happen from your side as you move towards implementation? Here are some of the things that we talk about also in this checklist. Questions related to the MCO's policies and procedures. I find it's helpful to have a three-column document that explains the 3 different MCOs and compare and contrast their processes with regard to policies and procedures, especially those that impact you day to day and how they're different. Some will be the same, but there will be differences among them. Specific provisions related to things that you need to understand with regard to bed hold and therapeutic leave. In one of the agreements, that's addressed directly. In the other 2, those are concepts that you probably will need to talk with the MCO about. How do supplemental payments work, dual eligibles, hospice, and respite? And that's all. If you have access to that checklist, you will be able to take a look. If you do not, feel free to give me a call, and I will send you a copy of that. All right, so one of the things that if you have not started this process yet, that's very important, is setting up a meeting with the contracting entities, the contracting bodies at the MCOs, and let them know the specifics of your facility. We talked about that, having a binder. Before you execute the contract, this might seem obvious, but this actually occurred. This is something that happened to a provider. Check the rates, the daily rates, whether or not there's anything added on for transportation, because it's a rare situation where there's an add-on for transportation. In the first in the first region, there were add-ons for transportation, but then the MCOs realized they had not actuarially prepared for that, so they pulled back on agreeing to that. So transportation is an issue where only in limited circumstances and only for one of the MCOs is there any transportation reimbursement that is separate and apart from the per diem rate. It's actually an add-on to the per diem rate, but you really have to argue and ask for it. So make sure those are specifically stated in your contract, because that is sort of a mess to straighten out if you've signed it and you've not already agreed to a number there. I touched upon this. The credentialing packets are very important. You have to make sure that they're accurate when they go in. If they're not accurate, it will slow down the contract process. And I've heard this and actually seen this for several participants in the MCO programs, home care agencies, and facilities themselves. And it is usually very tedious issues and not adequate documentation or even typos that slow down this process. So make sure that you're able to make sure that those credentialing documents are correct and are in quickly. You also have to make sure that you have licensing information for the individuals on your staff and make sure that that's complete and in place. It's a good time to check all of your background checks, all of your exclusion information, all of that important information. Make sure that's in order. And I think I can speak for a number of providers. It was a great opportunity to get all their ducks in order regulatory wise. Not that they didn't have those things done, but now they had them all in one place and easier to find, which is half the battle, right? We touched on these important issues: enrollment, ensuring timely payment. All of these are things that you have limited control on, but timely payment, if your claims going clean, the MCOs really have had a good track record of doing that. The MCO has to provide all participants with medically necessary emergency care, and they may, I repeat, may provide non-medical transportation at their own costs. So that's a discretionary provision, but there have been times where the MCOs have agreed to that non-medical type of transportation in unique circumstances. The service coordinator. I'd be interested in hearing what some of the more recently enrolled folks think. In the first rollout out in the Pittsburgh southwest area, the service coordinators, it was a rough transition to have service coordinators. There were some complaints that it was disruptive. There were too many folks in and out. And then I heard from other clients that they never heard from them. They hardly ever saw them, etc. So I think this whole service coordination process was really a big learning curve for the managed care organizations. In the Southeast, I heard many fewer complaints about what was happening, and that may be a matter of luck, or it may be that the MCOs really did become better at the whole process. It's important to set up procedures. My understanding is the service coordinators are required by their contract with either their employers or their contracts. Some of them are contract employees and others are direct employees. They are required to work with you to establish procedures, to be courteous, to set up times and appointments, to make contacts. So that might be one thing that if you find that that's occurring, that if you insist on it, they will do that. They are supposed to help with prior authorizations. with the managed care organization. And we talked a bit about the complexity of billing. I think actually the MCOs have become much better at the processes with regard to billing since the initial rollout. So, knock wood, you won't find the same sort of slowdowns and problems that they did in Region 1. What kind of residents are affected? The ones you would think, dual eligibles, recipients who are in a nursing facility, long-term support services in the home, those who are in the waiver processes, that is going now through the, so if you have a home care agency as well as a nursing facility, it is a good idea that your home care agency also become enrolled in the managed care organizations, especially if you have a high Medicaid population. And life programs. Life programs continue to be an option. Of course, their payment stream works a little bit differently than a standard nursing facility. The enrollments have been, enrollment packets should have been distributed. If they have not, you should contact the MCOs if you have Medicaid enrolled residents. The facility may not make direct recommendations. I know that in the Southwest, for the facilities that I assisted, it was attractive to make recommendations because one particular MCO had market share. Wendy, was that you?
Yes, excuse me. We do have a question. I wanted to jump in.
Okay.
Is there a rate scale available to review?
Yes, the state has published the rates, and you can find them on Department of Human Services website and in the Pennsylvania Bulletin.
Great, thank you.
Now, again, you may be able to negotiate add-ons. It's fairly few and far between. They like to stick with that published rate, but if you have special circumstances, you can talk with them about those special circumstances. Individuals, we were talking about participants, residents, becoming enrolled in the MCOs. They can change their plan at any time, but by any time, I mean in the middle of the month. It says right there, dating rules before the 15th of the month and the 15th after. So they can change at any time, but the MCOs themselves don't make the change in the system till that time. My understanding is that a lot of that residents are not jumping around, that it doesn't really make a big difference to them which plan is providing their care, except for in one area of the state, geography makes it a little different because one plan's network. So an individual's doctor may be in one plan's network rather than another plan's network, and that has been the big reason that residents have changed plans themselves. The independent enrollment broker is a contractor working on behalf of the state for the MCOs, and they're responsible for providing options and counseling individuals with regard to the varied MCOs. They also are not able to really make recommendations. So I'm not sure. My understanding is they do have information, logistics that do help participants, but they're not able to steer or say which MCO might be better for an individual. Nursing facilities, again, you may educate as well, but you can't make recommendations or steer them to a certain plan. And some facilities have gotten into a little bit of trouble for that. So The MCOs are, it would be hard for them to find that out, but I have had a situation where I've helped a facility where there was misspeaking on behalf of a counselor. So be sure to train your staffs well that that could be a potential compliance problem if you're actually counseling residents on their choices. Auto-enrollment criteria: if participants, residents are just waiting for enrollment to happen, or if there has not been good outreach by the MCO, there is sort of a pecking order about how they're enrolled. If the individual is already involved in a network and they're participating providers and there's only one CHC-MCO, then they'll be enrolled automatically in that MCO. If the individual has a DSNP, then they will be enrolled in the DSNP in the MCO who also has that DSNP. If they're transferring from Health Choices, if they're in a Health Choices, for example, that Keystone's Health Choices, they'll automatically be enrolled in Community Health Choices. And that occurs more when people are coming in from the community. They're auto-enrolled if they don't actually make a decision once the program is up and running. And if the individual is PCP, this one is the one that makes the most sense to me, is with a network provider, they'll be enrolled in that MCO. There is a lot of material out there that I recommend looking at and keeping up with, especially on the managed care organizations' websites and portals. I've given you sort of a very basic understanding, but they provide updates that will continue to refine their procedures, and that's where you find brand new information, something new that they're coming up with. And quite frankly, as we move forward, if managed care works the way it's supposed to work for some of those innovative programs and extras that may end up being very helpful and potentially lucrative, some cost sharing and risk sharing is expected, as you know, in the next 5 to 10 years. There's also information and specific training for various network providers. So if you're working with your ancillary providers, you may want to provide them with information about that so that they understand what's coming to prevent glitches in services and payment. We do recommend, and again, I was in talking through with PHCA some of this, that you develop a tracking for enrollment so that you can verify and provide services a little bit more fluidly month to month. So that's an operational type of consideration. But it's important to understand where you as the facility are enrolled, where your participants are enrolled, and where the varied providers that you work closely with are enrolled. And again, your various disciplines, RNACs and case management, all have to work closely with the managed care organizations.
Cindy, I do have another question.
Okay.
How does the provider learn which default MCO a resident has been enrolled in?
They can ask, well, they can look into Promise, I think, and that should say initially, which managed care organization the individual is enrolled in. And the participant in their paperwork, I think they're required to provide that information to you for billing purposes, but that may not always be occurring.
Okay, thank you.
I also think on DHS's website, There's an FAQ on that process too, and I think there is a link. I don't know it off the top of my head that you can request information, so long as you can show that an individual is a participant in your programming.
Great, thank you.
Service coordinators, we touched base on this. This outlines a little bit more information about some of the things that the service coordinators will do. Again, authorization, so that's very important. What requires prior authorizations, because that information will go through the service coordinator. Critical events, sentinel events, important transportation. Initially, it was set up that service coordinators would coordinate transportation, but that ended up being unmanageable, unworkable, and quite frankly, a disaster. So the MCOs have backed off that position because that just did not work out well at all. However, one of the things I always want to say is that service coordinators, it's probably getting better, but as it happened in the other geographies, service coordinators were generally brand new employees who did not have a lot of information or background, generally, not always, about nursing facilities, how nursing facilities work, how long-term care support services work. So although the MCOs did a good job in organizing these folks and training them, it still behooves you to talk with these folks and have them learn about your processes so that they better understand how things work and how you both can better serve participants.
Cindy, I have some other questions and comments.
Okay.
The comment is, can only identify name of CHC in the month they are enrolled, not prior to in promise.
Is that a question? I mean, that makes sense, that you can only look up and see if they're enrolled at that current date. Is that the...
That was a comment, I believe. Yeah.
Okay.
So a question is, if the resident goes into a skilled benefit does not, hold on a second. If the resident goes into a skilled benefit, does the MCO receive the updates and pay the skilled days instead of Medicare?
That is coordinated between, generally speaking, the Medicare organization and the CHC-MCO in the system. There have been times, I would recommend that you track that carefully, especially in the beginning, because initially, especially in the Southwest, that was a problem. I did not hear a lot of complaints about that in the Southeast. So I am assuming that process has been worked out, but I would track that in the first couple months for sure.
Okay, great. Getting back to the comment just a second ago, there is a more to it, meaning to say you cannot view promise for a future month, therefore will need to wait until January 1st for January CHC enrollments.
That is the way it did work. I'm thinking back in my brain in other geographic areas. That is the way it worked for other billing. You could not do that until January 1.
Okay, great.
Or, for the first time around, I think it was mid-year. So, okay.
Good questions and comments coming in.
For sure, and thank you for the clarification. Service coordinators, some other important things that they do, setting up behavioral health services. And I understand that there was some confusion with regard to behavioral health services, and it's no secret that behavioral health services are, it's a difficult program in Pennsylvania, probably every state. So it's one of those things, if you do have a participant, a resident, who needs mental health services, behavioral health services, proactive is always better. Discharge from the SNF to home and community-based services. The state has made no secret, and the MCOs are also making no secret, that deinstitutionalization is a continued goal to long-term supports and services. And I think some of what the service coordinators do is look to identify folks who may be better served in the community, and they also help with that type of placement. There are a lot of covered services that are not specifically, as they usually would not be, listed in the participation agreements themselves. I do recommend that you look at handbooks and also the Community Health Choices contract with the state, so that the MCOs, so that we hold the MCOs to their contracted requirement with states for the services that they're required to provide. They must have an exception process, and actually they've done that, and that seems to have been working very well. I have not heard of complaints with regard to the process, except that they do take a hard line and there are denials. The expanded services or value-added services, there is chatter in the MCOs about some additional services that they will create in what'll be year 3 and year 4, that will be as a result of some cost savings that they've done because they are managed care organizations. Those are not out there yet. I think too, in over the next couple of years, I think they will be, at least I've heard this anecdotally, they will be talking with providers and providing forums to talk about potential cost savings, wellness programs, value-added services that could benefit residents and providers and the plan themselves, which is ultimately, the goal of managed care. All of these things, they have in place a referral process that you do have to watch and be careful that your residents and participants are receiving everything that they need to receive, because sometimes the service coordinators are not as knowledgeable. You are experts on these particular residents, so I would recommend being diligent about that. Some of the other services right there are not necessarily a surprise. They are musts, but they're not outlined in your agreement with them. So there are things that I want you to be knowledgeable of in case there's ever an issue about it, that you can feel comfortable pushing back and looking at their overarching agreement with the state. Evaluations of persons with abuse and neglect, they will pay for those examinations. Hospice, and the payment process for hospice providers is a little bit different for each of the varied MCOs. So I would recommend, if that's a potential issue for you, to check their handbook. And again, we talked about nursing facility services, and this slide here talks a little bit about the ins and out of that in terms of bed hold days, therapeutic days, and it's important to track that in your systems. I know that you do now, and you did for fee-for-service, but it will be important for the MCOs as well. The MCOs, I want to talk a little bit about their audit and reporting requirements on behalf of the department. As the department used to do as direct Medicaid payor, there would be periodic audits. My understanding is the MCOs have not vigorously started the audit process yet, but they will be able to do that. There are certain parameters in the contract about their ability to come in and do both desk audits and online audits. So although it's not an important issue yet, it's very important to understand what might be some of those reporting requirements, what might be some of the things that they look at for audit. And it may not be something you want to talk with them now, but in the future you may want to do that. Staying up to date, the Commonwealth actually has, their website is full of information. They do have a Thursday webinar that's been hugely helpful throughout this process. Some of it's the same old, but very often there is something new on those webinars to learn and to take back. So it may be that you want to have someone on your staff or take turns listening in on that webinar to pick up brand new information as it comes out. Once you receive an executed contract, you'll be able to get onto the portals for the varied MCOs, and that is very important. That will be, especially if you have a large portion of your residents in one or all three of those MCOs. And then I provided some information to help you out. And I'm always happy to talk or discuss anything, or if you have an issue, feel free to give me a call. And I might be able to give you back a little bit more of your day here, and I understand that that's okay with the credits. So do we have any other questions, Wendy?
Not at the moment, but we'll open it up. If anybody does have any questions, please type them in the questions pane on the right hand of your screen, and we'll have Cindy answer them before we sign off. Thank you, Cindy, for your time today and for sharing this really important and timely information for us.
My pleasure. My pleasure. And again, like I said, if something comes to somebody and they want to bounce an idea or have thoughts, let me know. As you can tell, I mean, I've been through the process, but the operational stuff, it's a very moving target for you guys. So I feel for you in the implementation phase for sure.
Okay, we have a question. Have you had any experience with providers getting an extension on testing claims?
Yeah, I've had providers ask for testing before everything was up and running, and they were able to do it after the deadline. And it was sort of on the side, not the main. What the MCOs have done, there have been big batch testing, but I have had them agree to exceptions and run a test even after the contracting period.
Okay, we do have another question. Does the same service coordinator work with the resident in a SNF also work with them to place in HCBS, Home and Community-Based Services?
Yes, that has been my experience. The different MCOs assign them in different ways. One of them, I don't remember which one of them has, the service coordinators have like a couple different facilities. But if the individual in the facility, the resident themselves says, oh, I want somebody else, they don't like their service coordinator, the MCO is required to find a replacement. But the same one that's working with them, if the person wants to go into home and community-based services, or otherwise that might be a good placement, or their family member wants the same, that service coordinator will work with them to do that.
Okay. Going back to another question, just to clarify, a dual eligible resident will go under an MCO and will not be paid under PDPM, or is the Medicare benefit separate?
The Medicare benefit is separate, and I'm actually not completely clear as to how that interface works. I do recommend If you're a PHCA member, Gail Weidman is an expert at that stuff. So I don't want to give you the wrong information there.
And I will be sending in follow-up to today's webinar Cindy's contact information, as well as Gail and other members of our staff. If you have any questions, we're certainly here as a resource for our members. Okay, we'll give it another minute or two. I don't have any other questions at the moment, but we'll give it a minute. Okay, I don't see any questions, so I think we're going to wrap this up. Again, don't forget that I will be sending a survey. Please take a moment to complete the survey so that it gives us some good feedback on planning future webinars, and we'll pass that information on to Cindy. Great job today, Cindy. We thank you again. Just wanted to remind everyone to take a look at our website. We do have webinars scheduled through December, early December. So we have got 3 coming up in November and 1 in December. So to check our website and our weekly communications for details on those webinars and get signed up for credits. Great. Thanks again, everybody. Have a great day.
Thank you all. I appreciate it.